Hi, I'm Mike Saunders. I work at Bristol Children's Hospital in the southwest of England. Now behind me you can probably see Isambard Kingdom Brunel's famous suspension bridge. It was completed in 1864, roughly the same year I entered medical school at Bristol. Very pleased that Mike has asked me to talk about brachial cleft anomalies because it's one of my favourite subjects in paediatric ENT. The presentation is interesting, the embryology is interesting, the operations are quite fun and the outcomes generally very satisfying. Divided the talk up into sections and I hope you find it useful. Now, why do you actually need to know about embryology? Probably the most important thing for the trainees watching is that you're going to get asked about this stuff in the exam. It's an absolute sitting target for examiners because the stuff doesn't change from year to year, and even old blokes like me can ask you questions and still know the answer. Number two, like a Latin or Greek scholar who learnt how to form words at school, you may be able to impress your colleagues and bosses and make students think that you're terribly clever by telling them where the ear came from. But more importantly, realistically and seriously for a second, it is actually quite useful to know how congenital anomalies arise and therefore work out their likely anatomical course. And although I have to admit, I find embryology extremely dull as a subject in general, there are little niche bits that relate to paediatric ENT that are absolutely fantastic. So let's look at this little chap for a second. There's the nose, there's his eye, there's his heart, liver, and upper arm. And there are these four ridges you can see, look a bit like double chins. There's the mouth. And these are your brachial arches. This is the embryo at 32 days. It takes me about 32 days to answer an email on average, and this has arisen in 32 days from one cell, so quite extraordinary, the developing human. Now, if you were to look at this little bit of brachial arch anatomy by getting this chap and slitting him down the back like a fish, you'd look at this sort of view. There's the top where the mouth is, there's the bottom where the laryngeal orifice is, and each of these ridges is a brachial arch. It has a nerve and it has an artery. Very important point we'll come back to in a bit. That's the arch. Now, the second most important part is that on the outside, you've got these dents that are known as clefts, and on the inside, they're known as pouches. On the outside is ectoderm, and on the inside is endoderm. If you were to just get one of these bits and look at it a few days later, you'd find this appearance. There is your first cleft, your first pouch, and that's creeping towards each other, and that's going to form the ear and the eardrum and the middle ear and the eustachian tube. But the three clefts on the outside have disappeared and unified to form one big hole called the sinus of His. The pouches, which are on the inside, are still there. Move on a few days more, and this has happened. So your ear is almost there. The cleft has met up with the pouch. You've got the eardrum in the middle, the ear canal, the eustachian tube. But all of those other clefts have disappeared and left you with one little blob called the cervical sinus. That too is going to disappear in time. The pouches on the inside are still going strong, turning into tonsils, parathyroids, and the ultimobranchial body, and so on. This is a very commonly printed and published picture and table, which sort of demonstrates what happens to all the bits of brachial arch, and widely used in the exam. So as I mentioned, each arch has its own nerve. The first arch is the trigeminal, the second arch is the facial. And this is why in the middle ear, tensor tympani is supplied by the trigeminal nerve, and the stapedius is supplied by a branch of the facial nerve. The third arch is supplied by the glossopharyngeal, and the fourth arch by the superior laryngeal branch of the vagus. There is actually a fifth arch which stays around just about long enough to get a name, and then it disappears completely, a bit like it with the eighth. And there is also a sixth arch which goes to form cardiac stuff, which we're clearly as ENT surgeons not quite so interested in, and that nerve is the recurrent laryngeal nerve. First brachial cleft anomaly, and I'm quite specifically calling it a brachial cleft for this reason. Let's go back to this little picture of the arches and how they got formed. This is the pouch coming from the inside. It's not related to that. This is the arch, which is all the soft tissue stuff, not really related to that. This is the cleft. And a first arch is effectively some sort of duplication of this, the ear canal or the first cleft. So it is actually, technically and most accurately speaking, a first branchial cleft anomaly. Now, they exist in a couple of forms, depending whose classification you want to listen to. The most widely used is this one, the work classification, dating back to 1972. This suggests that there are two variants, one of which is simply a cystic duplication of the ear canal, which is relatively lateral, superficial to the facial nerve, and not terribly complicated. And it's purely ectodermal. Obviously, you can't tell that just by looking at it, but what ectodermal only means is it doesn't have stuff like cartilage and advexal skin structures in it. So quite straightforward. Type 2 is a more complicated duplication of the membranous external auditory canal, not the bony one, the membranous one. So it's got ectoderm and mesoderm in it, which means it's got all sorts of stuff in it, and it can be superficial, going through the middle of, or deep to the facial nerve, and that's very important, obviously. Other classifications are available. You may need to know this for the exam. In clinical practice, tend to use them very much. The Olsen classification simply said it's either a cyst or a sinus or a fistula, which is pretty straightforward, but not greatly different to what we do in real life. And there's another one called the Arnott classification, 1971, not widely used, sort of similar to the walk one, but without the underlying embryology bit lobbed in. So, number of authorities have pointed out that the classification systems, like a lot in ENT, aren't perfect. So what to look out for? Fistulous opening below the level of the ear canal on the skin, not above. That's a pre-auricular sinus, and it's not really anything to do with this. It's below the level of the ear canal. Recurrent infection, the parotid, deep sort of swelling behind and just inferior to the pinna, or an anomaly in the floor of the ear canal, and that can occasionally involve the tympanic membrane as well. It goes a long way medially. So this is one of the more superficial, probably what you would call a walk type 1, which is just a cystic duplication of the ear canal. This one's got infected, so it's a bit of a mess. There you are. There's another one that's got even more infected. This, on the other hand, is one of the slightly more complicated ones that's likely to be a duplication of the entire membranous ear canal. So this thing that looks a bit like a recurrent infected spot is in fact the opening of a fistulous tract. The top end of it is here in the floor of the ear canal. In fact, this opening actually involved the tympanic membrane. So there was a sort of acquired cholesteatoma behind the drum as well. So this chap actually, as well as needing the neck surgery, needed a mini tympanomastoid procedure at the same time. So these are the classic type 2 first cleft fistulas with a small fistulous opening going up to the ear canal. They're sometimes known as a coloral fistula as well. It's all the same thing. Here's one in a grown-up with even a little bit of goo being expressed out of it, just to ram the point home. Now, imaging in these cases isn't massively useful in that it won't tell you whether the facial nerve goes superficial or deep to the tract of it. It may give you some helpful information about quite how extensive the lesion is under the skin. So we nearly always wind up getting an MR rather than a CT. Here is a nice operative picture of a first cleft fistula, type 2. There's a little lacrimal probe in the skin opening. There's the actual cartilage of the duplicated ear canal. There's the pinna pulled up with the suture. Facial nerve is down there. So in this case, the facial nerve is deep to the fistulous tract, although you wouldn't have known it when you started the surgery. Here is one that's a little bit more scary. You can see that the actual fistulous tract has been disconnected from the skin there, and it's going deep. There's the trunk, the main trunk of the facial nerve there running right over the top, and there's the pinna up there. So if you're going to set about operating on these, you need to know how to find the facial nerve in children. And that's slightly different to doing it in adults. You need to be confident in so doing. In fact, in Bristol, what we tend to do is to get one of our adult head and neck colleagues to come and give us a hand, because it just makes everything a little bit easier. I've got pediatric colleagues around the country who do a lot of pediatric carotid work, and they're happy to take these on their own. Key thing is to effectively do the same approach you do for a parotid lesion and identify the facial nerve first, and then dissect the tract out from below it or above it. Sometimes the tract is said to split the branch of the facial nerve as well, so it can be quite complicated. Now we're going to talk about the commonest group of branchial anomalies, the second branchial cleft anomaly. These are the majority of the ones you're going to see. They're occasionally bilateral, commonly unilateral. They have a classic opening at the lower anterior border of sternomastoid. It can be a blind ending sinus, which is relatively short. It can be a complete fistula going all the way into the pharynx, where it opens in the posterior aspect of the tonsillar fossa. Going back to the embryology for a second, if you remember, the second pouch is here, the second arch has joined up with arches 3 and 4 to form this sinus of His. And theoretically, if it's a complete fistula, the course is going to go all the way through here. So you could call it a second cleft fistula. You could call it a second pouch fistula. What you probably can't call it is a second arch fistula. In fact, that's what I've been calling it for the last few years, and I realized I've been completely wrong. It doesn't really matter, but it's a nice semantic point. Now, if it's just a blind ending sinus arising from an opening on the skin, like this, for example, which is the theoretical cause of it, you can't really say whether it's a second cleft, a third cleft, or a fourth cleft, because it's come from one of the 3 of them. Theoretically, it might have a sort of fibrous connection here or here, in which case you could be accurate about it. It's probably best just to call them branchial cysts rather than trying to attribute a number to them. Here is the theoretical course of a second branchial cleft stroke pouch fistula into the neck, between the internal and the external carotid, right into the tonsillar fossa. So relatively scary, but actually in practice and surgery, it's not as scary as it seems, because you stay close to the tract during the dissection and don't cut anything you don't need to. Here are some cases of second cleft skin openings. Sometimes it can be quite sore, recurrent infections, sometimes almost invisible. I think it's that dot there. That's a freckle. That's a freckle. There's a fairly red one there, and there's one with a cartilage bit in it as well, which you often see. So, do you need to operate? Well, not always. If it's actually just dry and a little hole and not causing any trouble, it's probably not going to cause any trouble, and I'd be happy to leave it. If it's discharging a lot, it means that there's a decent sized sinus or a complete fistula, and probably that'll get blocked up and turn into an abscess. So yes, I usually advise surgery if it's discharging a lot, usually from the age of 1 upwards. Preoperative imaging I don't find terribly helpful. They're often referred in with a pre-op ultrasound, which may or may not show you a tract. I don't see any point in cross-sectional imaging because it usually involves a general anesthetic, and it's quite difficult to spot the tract. This is a lovely old-fashioned thing where you used to get a child and stick a cannula in the opening and squirt dye in, and you get these beautiful fistulograms. Great for talks, I suppose. Not really that necessary. Quite difficult to do on a modern 2-year-old as well. They're quite wriggly, and also involves x-rays, so we don't do these anymore. What I do is the on-table fistulogram involving methylene blue. You get a 1 ml syringe, some methylene blue and a small Vempron, and you stick just the plastic bit, not the metal bit, just the plastic bit into the sinus opening and squirt. If it's a complete fistula, it comes out in the mouth. In this case, it's trapped up alongside the nasotracheal tube, but you can have a look in the mouth, see it coming out in the tonsillar fossa. Now, if it is a short tract that you've probed and the dye doesn't go all the way through, you may feel that you can do an operation just using the 1 incision and get it all out. If it's a complete fistula and an older child, you will need to do, or traditionally you'll need to do what's known as the stepladder incision, where this is around the opening and this is higher up. And you need the higher up incision to give you access into that area where you're going towards the pharyngeal wall between the heads of the carotids. Now, this is 2 quite big scars. So I've made a slight modification of this in my own practice, which I call the minimalist technique, for want of a better phrase. You get a lacrimal probe and you shove it into the fistulous tract and leave it there, and you tape that down so it doesn't come dislodged. You then make your large incision, excuse me, up here, which gives you access to everything. What you can then do, because you've got the tract identified with this metal probe, you can dissect down onto it, follow it down to the skin from the inside, and then cut it flush with the skin from the inside, rather than making a big hole from the outside. And you are following it down with blunt dissection I tend to use, with therefore clips rather than lots of cutting. And there you are. This is the lower end of the fistula tract disconnected from the inside. And you've got a tiny little scar there rather than the great big 2-inch scar that's traditional. That's it at the end of the operation. So we've done all the proper work through the bigger upper incision going into the wall of the pharynx, doing the deeper dissection, and the lower end has just been left with this tiny little hole that looks much the same size as a drain hole. So it's a cosmetic advance because people are very aware of cosmesis nowadays. Surgically, it really isn't much more complicated, and I suggest you give it a try. You don't need to take the tonsils out. This is a nice picture from my training where one of my consultants persuaded me to take the tonsils out and then stitch them to the tracts that we dissected out from the outside. Very difficult to do in real life. There has been some study, retrospective largely, that suggests that taking the tonsil out doesn't make much difference. All you need to do is take it out from the outside and tie the tract off as close to the pharyngeal wall as you can. You stay on the tract with your dissection with blunt spreading technique. You don't cut anything that you don't need to, and that's how you can go through some fairly major clockwork without causing too much trouble. Now, this is the classic brachial cyst. It's the smooth swelling arising at the anterior border of sternomastoid that we all know about. It doesn't just arise in children. In fact, in my experience, it tends to arise in teenagers and people in their 20s as much as it arises in toddlers. This is complete overkill, getting an MRI scan for brachial cyst. It wasn't my idea. It does make a very nice picture for talks. Normally, I suggest an ultrasound only. They tend to arise as painless swellings that tend to enlarge sometimes quite quickly and worry the parents. They're usually cystic, but sometimes they can feel a little bit firm. So let's just talk about the embryology, sorry, again. It doesn't have an external connection, so you don't know whether it's a second, third, or a fourth cleft thing. It's probably just arising from that thing, which is what the sinus of his turns into. So it could be any of the three. Sometimes people say they can dissect out a deep tract that goes towards the tonsil, meaning it's probably from the second arch, but it's a bit academic. In real life, you tend to just dissect out the cyst on its own and everything is fine. So do you need to remove them? Well, yes is the honest answer. There's a number of reasons. One is in adults particularly, but also in children. Sometimes when they're a bit firm, you want to get it up because you want to be sure what it is. So in adults, there are lots of case reports in the literature of brachial cysts that turned out to have squamous cell carcinoma in them. And there's a huge amount of theoretical debate about whether or not this was a brachial cyst in the first place that happened to go malignant. Realistically, what it is a cystic degeneration in a metastatic deposit in a lymph node. So you need to send it to histology. And of course, if you find one, you've got to go looking for the primary. Secondly, cosmesis. 12-year-old girl here does not want a lump like that in her neck for the rest of her life. So clearly she's going to want that removing very carefully. Thirdly, they do get infected. And once they get infected, further surgery then becomes slightly more complicated and the outcome cosmetically is going to be worse. So yes, they do need to be removed. Investigations, if it's a child, you don't need to do an MRI scan. You don't really need to do anything. Normally NT examination and history and a pre or ultrasound. And an ultrasound usually tells you that it's cystic and you can confirm the diagnosis. In an adult, as well as the ultrasound, you need to do fine needle aspiration cytology because particularly an older adult, you have to think about the risk of this being a cystic metastatic squamous cell carcinoma node. So as well as all that, flexible nasal endoscopy in clinic with full ENT examination. Now we're going to talk about third and fourth pouch anomalies. First thing to say about these is these are incredibly rare, or certainly when I was training, these were incredibly rare. I only saw 2 during my entire training, and those were both at Great Ormond Street. Now, since my new colleague Julian Gaskin was appointed a few years ago, they seem to have come much, much more commonly into the Children's Hospital in Bristol. And I don't think this is particularly just Julian's fault. I think it's due to the fact that there's a greater awareness of the existence of these things. And I've also found that we've had many more first arch, or rather first cleft abnormalities referred to us in the last few years. And again, I think that's because of a greater understanding out there in the ENT community. So apart from being rare, the next thing to say about third and fourth cleft anomalies or pouch anomalies is that they don't usually have an external opening like the second classic cleft fistula. We did have one recently that had an external opening because an infected process eroded through it. It had become a fistula, but it wasn't a fistula at birth. In theory, if they did have a genuine external opening, it would be in exactly the same spot as the second cleft, because they all arise from the sinus of His or the cervical sinus. So you can't tell them apart from the outside. But the opening on the inside for these two is in the piriform sinus rather than the tonsil. And the textbooks say that the third branchial pouch anomaly has an opening in the rostrum of the piriform fossa, whereas the fourth pouch anomaly has an opening in the apex of the piriform fossa. Now, I didn't even know that the piriform fossa had a rostrum until I was doing this talk, but I can't say I've noticed the difference in them clinically. I'll come on to that a little bit more in a second. So back to our embryology boy. Here we are with our first cleft, our first pouch, our 2, 3, and 4 pouches in the middle, and our sinus of His, that's the result of clefts 2, 3, and 4 fusing on the outside. So in theory, if you had a third cleft or pouch fistula, it would go from the piriform fossa through the neck and out into the skin like this, and so would the fourth. But in fact, that's not what you get. In real life, they start on the inside and then they peter out somewhere in the neck. In the fourth one, classically somewhere around the thyroid, but also the third ones often turn up somewhere around the thyroid. So what they tend to present with is recurrent abscesses in or around the lateral lobe of the thyroid. So the only remaining branchial bit of these is the pouch bit, the opening on the inside. So they're best known as third and fourth branchial pouch anomalies. But of course, we all call them third and fourth branchial arch anomalies, even though it's semantically wrong. It doesn't really matter. I'm just being a bit of a nitpicker. Going back to this one, which you'll remember, the nerve of the fourth arch is, of course, the superior laryngeal branch of the vagus. And the reason this is important is that this then governs some of the root of these two fistulas. So although the second one is relatively straightforward, coming from the tonsil, coming all the way out like that, the third one starts off in the piriform fossa, hooks over the superior laryngeal nerve, and then down into the neck somewhere near the thyroid. Now, the course of the fourth one, there you are, starting somewhere in the piriform fossa, but lower down, going right down alongside the trachea, into the mediastinum and back up again. Nobody's ever demonstrated a complete fistula like that, so it's only ever going to be bits of it. But the main thing is that there's an opening in the piriform fossa, and you get recurrent neck abscesses. So the actual distinction between a third and a fourth arch, in my practice at least, is largely academic, fascinating though it might be. Right, here are some theoretical pictures of the anatomy. A third arch somewhere in the neck coming out of the piriform fossa, and a fourth arch, I'm calling them arches again, they're pouches lower down. Here are some more nice pictures that I've nicked off the internet. And the key thing here is the fourth pouch anomaly is going underneath the aortic arch, somewhat outside my normal territory of surgical ability. Luckily, we don't ever have to dissect them out, certainly not in my practice. The third one not going quite so far down. So they usually present with complex, multiple, recurrent neck abscesses. And certainly when I was a trainee, you would see children referred to a specialist centre with 7 or 8 different scars on the front of their neck where they'd had incisions to drain what thought to be simple lymph node abscesses. And eventually the penny dropped and they got referred for further assessment. And then someone thinks to look into the pharynx and the piriform fossa, and lo and behold, there's a sinus opening there. This is one which was a third or fourth arch, I think probably a third, that presented with recurrent neck swellings. And this is the corresponding MLB finding. There is the opening of the esophagus. The beak of the laryngoscope is put just posterior to the laryngeal opening there. So this is the top of the piriform fossa. But suppose this is the rostrum of the piriform fossa, and there's the sinus opening there. Here I am probing it with a sucker, and I couldn't actually get the sucker very far in on this particular case. Now, rather than dissecting the whole thing out like we do with a second cleft or pouch fistula, what people have found very effective is simply sealing up the sinus opening in the piriform fossa. And the best thing for that is a urology or general surgical laparoscopic ball diathermy. Here you see it stuck in there. You simply diathermy it a little bit, being careful not to overdo it because the recurrent laryngeal nerve's somewhere around here, and you're causing a lot of scarring. And essentially what you're trying to do is get the thing to close down. And generally speaking, that is very effective. It's worked in nearly all the cases we've done in the last few years, and most of the cases in the literature. The theoretical risk is that you seal off the top of it and then leave a sort of closed bag of goo sitting next to the thyroid, which then gets more infective, and you wind up having a more complicated open neck procedure than you'd have done in the first place. But most of the time, this simple step, which is really quite easy to do, seems to avoid the need for further surgery. Now, this is a picture of a girl who presented with recurrent neck abscesses on the left side, had 2 incisions and drainage, but she came up to us relatively early and had an MRI scan demonstrating a complex mass related to the left lobe of the thyroid. And we diagnosed a third or fourth patch brachial anomaly at that stage, and persuaded her father that she needed to have a more formal procedure. By the time she came to formal treatment, in fact, saliva and liquid had started leaking out the neck. So this is one that had become a fistula as a consequence of infection. So we elected, rather than just diathermy the tract off from the side, we elected to do an open procedure here because we thought there was probably more infection and risk for infection in the neck. And here is the neck opened up, and here is the rather complex and very scarred mass associated with a bit of the lateral lobe of the thyroid. And I think down there is the recurrent laryngeal nerve on that side. But I got one of my adult head and neck thyroid colleagues to come and do this with me. And I'm very glad I did, because it was really, really very difficult. So look at this small chap. He has got microtia on both ears. He's got a little skin tag there. He's got a branchial cyst on this side with a little hole over it. He's got a little sinus opening there. He's got bronchio-otorenal syndrome. You need to know about this for the exam as much as for clinical practice. Realistically, in real life, it's quite rare. It's autosomal dominant, variable expression. Prenatal testing is available. This slide might be a little bit out of date, so there may be more up-to-date information available. Do you need to refer everybody with the branchial sinus or fistula for this, for testing, for a hearing test and genetic testing? No, you don't. And the reason is this. Criteria designated to try and make the diagnosis. There's a family history. Yes, refer them for a hearing test. If not, look at this lot and decide whether they've got 2 or 3 major or minor criteria. And if they've got the requisite number of features, then get a hearing test, refer them for genetic testing. And that really, in a nutshell, is bronchio-otorenal syndrome. So that's it. I hope you found that interesting and informative. Mike and Shahid, thank you very much for asking me to take part in Masterclass. A great privilege. Thank you very much. Goodbye.